or afternoon, depending on where you're joining us from the globe. My name is Nonhlanhla Ngwabi. I'm with ICANN, and I would like to welcome you all to our webinar series 6, week 5. And for all participants, please note that if you attend 4 to 6 out of all the weeks, and you attend for at least 60 minutes, you will get a certificate of attendance. Our series is addressing infection prevention and control, focusing on leadership and management. Today we have 2 speakers, and today they'll be discussing how to set up an infection prevention and control program, as well as project management as a tool for leadership. Just some things that you should note so that we do give you maybe quality presentations. Please keep yourselves on mute, and please do not turn your cameras on. Keep your cameras off and keep yourselves on mute. And then if you've got any questions, please post them in the Q&A box. Please do not post in the comment section, because we'll not be able to attend to them, and we cannot also attend to raised hands. So for any queries, concerns, or anything that you'd like maybe for us to address after the presentation, please put it all in the Q&A box. With that being said, I would like to introduce our first speaker, Dr. Patrick Kabwe with the African CDC, to give us an update on the COVID-19 situation in Africa. Over to you, Dr. Kabwe.
Thank you so much. Just sharing my screen. Hope everyone can see it. Okay, can we all see my screen?
Yes.
All right, thank you. So good morning, good afternoon, colleagues. So this afternoon, I'll take you through the epidemiological updates of COVID-19. So on this slide, as of 9 a.m. Eastern African time today, over 131 million cases and over 2.8 million deaths have been reported globally. And this is giving a case fatality rate of 2.2%. And Africa accounts for about 3.3% of the total cases reported globally. And seeing on the right is actually an epic curve. And we are seeing more and more cases actually being reported from the Euro region and the Americas region. So this slide is showing the trend of COVID-19 cases from the beginning of the pandemic to date in Africa. So the epi chart is showing the number of new cases shown on the y-axis, reported by day, shown on the x-axis, and the 7-day moving average, which is shown by the red line. So for 5 member states, have reported 100,000 cases and or less. The new cases being reported from across the continent has continued to decline this past week, shown by the 7-day moving average. However, the eastern and northern regions are currently showing an upward trend in new cases. Cumulatively, over 4.2 million cases have been reported, and over 114,000 deaths have been reported in Africa, giving a case fatality rate of 2.7%. And of these cases reported, 90% have actually recovered. And I think important to note that the case fatality rate is quite way above the global average. So this table is showing the distribution of COVID-19 cases, deaths, and recoveries by AU regions. So in the last 24 hours, over 5,700 new cases, about 173 new deaths, and over 7,000 new recoveries have been reported from 55 states in the regions. 51% of the new cases have been reported from the eastern region. So this slide is showing the COVID-19 case fatality rate by AU member states. So there are 5 categories here. So we are seeing 23 countries having a case fatality rate that is between 1 to 2.2%. We're also seeing 18 countries having a case fatality rate that is between 2.2 and 5%. 10 countries have a case fatality rate that is less than 1%, while 3 countries have a case fatality rate that is greater than 5%. So finally, we'll take you through the testing that Africa's CDC and through, of course, the member states have conducted. So over 40 million tests have been conducted across the continent. The overall positivity rate currently stands at 10.5%, and the overall test per case ratio currently stands at 9.5 tests per reported case. And this is actually lower than what is Africa CDC is recommending, and it might actually indicate that many cases are likely going undetected in some of the member states. So I'll end here, over.
Thank you so much, Dr. Patrick Kabwe, for that presentation and that informative update on the COVID-19 situation in Africa. At this juncture, I would like to introduce Ms. Alethea Mashamba, who's a seasoned nurse practitioner with more than 40 years of demonstrated clinical and public health experience. She's currently with Infection Control Zimbabwe in ICAS, and she'll walk us through how to set up an IPC program. She'll walk us through step-by-step developing of an IPC program. Thank you. Over to you, Ms. Alethea Mashamba.
Good morning, good afternoon, everyone. Can you hear me?
Yes, we can.
Hello.
Just go on, Ali.
Yeah. I'll be sharing with you our experience on how to set up an IPC program. That's the outline of my presentation on IPC development and what structures one needs to set up national and a program up to the lower levels, and then strengthening the management of a national IPC program. And then I will also cover training and capacity building strategies for infection prevention and control, then the COVID-19 response and preparedness, including M&E and reporting, and the challenges that you can possibly face. Any IPC program to prevent transmission of infections in health facilities should be embedded in a facility IPC program. This is guided by the WHO core components of an IPC program at national and facility level. And the components are existence of an IPC focal person who is trained in IPC, and an IPC committee or team. And then you also need to have IPC guidelines and SOPs, including policies. And then those policies cover mainly the standard precautions, transmission-based precautions, and you should also have in place a system for monitoring of IPC practice that includes risk assessments to inform the policy. And then you also need surveillance a system of surveillance for healthcare associated infections and multi-drug resistant microorganisms, including training of healthcare workers. So I'll share with you how we went about in Zimbabwe setting up our IPC program. We established guidelines in 2013, which include a national IPC policy, strategic plan, M&E, and related tools to guide implementers. Then at national level, we have what we call a national IPC committee with 3 technical working groups. One looks at infrastructure, the other one looks at training, and the third one looks at M&E. And then we also had a program on in-service training of healthcare workers who were already in the field. And we established a pre-service training program for those who are in training. In each province, we have an IPC coordinator. We have 10 provinces in Zimbabwe. We have an IPC coordinator who leads a team of certified trainers. There are about 5 to 6 in each province, and some have been trained at diploma level. And then we also strengthened the Infection Control Association of Zimbabwe, and it has linkages with the Infection Control Africa Network. And we also developed a national healthcare worker TB policy for screening and protection of healthcare workers. It's still in draft form, but that is what we've been using to train healthcare workers on prevention of TB. Again, related to the program, we also developed tools to evaluate the implementation of IPC programs at departmental and facility levels. And these tools led to the development of facility-specific IPC plans and standard operating procedures. We put in place, following the face-to-face training, a follow-up program of mentorship and site support visits. And we conducted several of these in order to support the trainers and monitor the implementation of IPC activities at facility level. In order for our IPC teams to get support, we made sure that we brought managers on board at provincial and district level so that they can support the training that our trainers were conducting. And then we carried on an extensive training and orientation program on the use of data that they find from the tools that I identified the gaps in order to put in place a program for improving IPC performance. And we went through the technical working groups at national level. We developed IPC indicators that we have over the time negotiated for IPC indicators to be linked to the National Information System. And this is an ongoing exercise. Within those indicators, we report on TB among healthcare workers. We report on surgical site infections, and we are in the process of, and COVID among healthcare workers. And we are in the process of negotiating for more of the national IPC indicators to be absorbed into the health information system. Now I'll share with you what we put in place in response to COVID. Like I said earlier on, COVID response should be embedded within an existing IPC program at facility and national level. As Zimbabwe, we responded to a call from the WHO for at the onset of the pandemic for countries to put in place a whole government and a whole society response, including through implementing a national cross-sectoral COVID-19 action plan that outlines the immediate and long-term actions with a view to sustainability and strengthening the health system, social care and support system, preparedness, surveillance, and response capacities. So this, the guidelines for countries are in this well-documented document. So consequently, as Zimbabwe, we established 10 pillars at national level in March 2020. First pillar is for coordination, planning and monitoring and evaluation. Another on risk assessment and community engagement, surveillance and rapid response teams and case investigation. Points of entry, as you know, we are a landlocked country, and laboratory system, and pillar 6, to which we belong as infection prevention and control. And then a pillar on case management, logistics, procurement, supply management, continuity of essential services, which was also very important because COVID, everybody seemed to now forget about everything else and focus on COVID. And then we also have law enforcement and security. Now I will discuss the activities of the IPC pillar and their roles and responsibilities. The pillar is led by the Director of Nursing Services and co-chaired by ICAS, Prof. Robertson represent us on the as co-chair on the pillar. The overall objectives of the IPC pillar is to limit the transmission of COVID-19 in communities and health facilities by adherence to the IPC guidelines, which were already in place, the protocols that I will share what we put in place, and ensure a rapid implementation of IPC activities. The activities included development of a COVID-19 operational plan and budget, establishment of IPC reference materials for use at national and health facility level and community level. And IPC capacity building started at all levels of the health system, from community level right up. And we also established a PPE supply management and local production system. And we were tasked to monitor the quality of the PPE produced locally and as IPC pillar. And then the hospital infrastructure, we made recommendation in relation to IPC repurposing of existing buildings and upgrades in order to cope with the COVID-19. And then we also put in place a program for IPC assessment, monitoring, and evaluation. And we were consulted by all the pillars, and we shared our information with the other sectors. So we used the WHO multimodal strategies to fight COVID-19. The first one being system change, which is needed to enable IPC practices, including infrastructure, policies, equipment, supplies, and other resources, which I shared earlier on through the other pillars. And then we put in place a training and education program to improve healthcare worker knowledge. And we put in place an M&E and feedback to assess the problem, drive appropriate change, and document a practice improvement. The pillar worked to develop promotional material to inform communities and healthcare workers, reminders, in order to promote the desired actions at the right time, including a lot of advocacy and behavior change. And our IEC strategy included print, radio, and also a lot of during meetings. And then at institutional level, we tried to also create a culture of safety to facilitate an organizational climate that values the COVID-19 preparedness plans, with a focus on involvement of senior managers, including champions and role models among staff. These are some of the documents that guided our policy and COVID response and preparedness. Like I said, these were built on existing policies. We had guidelines before, so we updated our guidelines and developed standard operating procedures to respond to COVID-19, including guidelines for communities and households, those who were managing people at household level, including a national PPE policy that we encourage institutions to use as a guide to develop their own institutional PPE policy and work out their requirements. So in terms of training, we developed modules to train clinical staff and non-clinical staff. So our IPC capacity building was rolled out to all levels and to everyone, leaving no one behind. We had presentations on advocacy for health professionals, including managers, laboratory staff, updating the national IPC trainers' knowledge about COVID. So for health professionals, we had the 3-day training. We ended up merging IPC and case management because we realized these were the same stuff that were being called by case management and also IPC. So we developed modules that talk to both case management and IPC. And then for the non-clinical staff, ambulance drivers, mortuary attendants, we had a 1-day IPC COVID-19 for all support staff. And then we also developed an IPC training for port of entry, for the port of entry pillar to use at the quarantine centers. So there was a lot of training that went on. In terms of getting management on board to support the COVID-19 response and existing IPC programs, to us, COVID was a blessing in disguise in a way, because some institutions were leaving IPC issues to the IPC focal persons. But with COVID, we ensured that we get the management on board. We strengthened the leadership and aligned it to the hospital management board, the hospital executives, so that they can support the COVID-19 response and management team and put in place strategies for both clinical and non-clinical staff. For the managers to also positively influence the quality of care, we encourage them to do walkabouts to make sure that they know what is happening from the entrances of their hospitals to admissions throughout the hospital. Because one of the things that we asked them to encourage them to do was that as a manager, if you know your hospital, you positively affect patient care when patients are seeing you, and you're encouraging your healthcare workers as they are working. And you will also observe the rational use of the resources and also advise on the job. And this will lead to quality improvement and good patient outcomes. And it also improves your institutional reputation. This we use to encourage managers to really have a hands-on. And in the process, we ask them to clearly define roles of the hospital executive in creating a safe environment for both staff, patients, and visitors. So as a result, IPC practices were strengthened, procurement of essential supplies was made available, and although there were shortages, but managers went out of their way to make sure that the supplies needed were in place. There were improvements in the cleaning of the hospital. We upped the cleaning practices from once a day to 3 or more times a day, including relook at the laundry services. And we put a lot into management of the patients and public relations, so that the public gets to know what is expected of them at the hospital. And we ask the managers to lead by example, be role models and champions in IPC, and also look at staff welfare, because COVID brought a lot of stress with shortages of staff, shortages of supplies. We anticipated a lot of burnout, so we asked the managers to be empathetic, to put in place counseling support services, acknowledge staff, provide incentives, not necessarily monetary, but even extra days off, in order to demonstrate empathy and understanding that staff were working under very stressful and challenging conditions during COVID. So these strategies, again, this I've talked about improving the screening, triaging, and early recognition, standard precautions for all patients, transmission-based precautions, and looking at the administrative controls, the resources, supplies, to ensure that the policies and control measures are in place. And we also looked at the environmental and engineering controls and developed the IEC materials in all languages. So in summary, this is what I was talking about. I would like to emphasize that our PPE policy was a challenge because initially everybody wanted to wear a full hazmat suits, but with education and training, we asked institutions to develop their own institutional policies on who should wear what and how to wear it and when, and this helped a lot. So finally, although we've conducted a lot of training in response to the pandemic, and the ministry, the government allocated additional posts for IPC matrons at central, provincial levels and sisters in charge at district level. And most of these, we got at least 130 posts throughout the country. So COVID helped us have IPC practitioners in place. So, however, most of these were newly appointed cadres, had no training and orientation. So our training for the new staff is ongoing so that they are up to date with the appropriate COVID-19 responses. We also looked at the nurse tutors in nurse training schools who need an update in order to incorporate new information in their teaching. And then we are also strengthening the skills development on IPC skills through observations like hand hygiene, waste segregation, things that people, and wearing of PPE, things that people need to know in order to practice safely. So we focused on the primary care levels through mentorship and site support, and we are ongoing, we are carrying on with our COVID capacity building through Zoom platforms, WhatsApp groups, and people are really responsive. We have an M&E system to monitor practice, and we are continuing to negotiate on the IPC and COVID-related indicators through our NIPCC and the technical working groups in the Ministry of Health. So the challenges that we faced during COVID, it's that training does not always translate into action and behavior change. There's need to follow up and monitor change in IPC practice. And this we do through mentorship, site support, and confidence building to assist the institutions, engagement of managers, and then important is to strengthen our occupational health programs for healthcare workers in order to make sure that we link our COVID screening to the NCD and TB screening services. So there's ongoing training, and our uptake for COVID-19 vaccination has been slow, but through mobilization and dispelling of myths around the vaccines, this has increased demand. So that is what we have put in place in terms of strengthening IPC and COVID-19. Thank you very much for listening.
Thank you very much, Ms. Alethea Machambo, for that very comprehensive presentation, which touched on how Zimbabwe set up the infection prevention and control program, and also touched on what's important right now and what's going on globally, which is the COVID-19 pandemic, and the country's response and preparedness program, looking, of course, at the IPC pillar. Just a reminder, I can just see in the comments as well, people asking about certificates. We did mention in the introduction that you will only get a certificate if you've attended 4 to 6 of these sessions. And if you attend and stay on for at least 60 minutes, you will get a certificate of attendance. And then as well, just a reminder, because I see it in the comment section as well, that these sessions are recorded. And if you're registered, this recording will be made available to you. So if you've got any questions, please put them in the Q&A box for all our presenters, and those will be addressed at the end of all the presentations. And then moving along, I'd like to introduce our next speaker, who is Professor Debola Olanyika, who is a clinical and public health microbiologist and infection prevention and control specialist from NSIC and ICANN, Nigeria. So she will talk to us about project management as a tool for leadership, quality improvement in infection prevention and control, and resources for successful infection prevention and control programs. Thank you, and over to you, Prof.
Good morning or good afternoon, everyone. So I kind of have a 3-in-1 presentation. We're going to touch a bit on leadership. We're going to talk on project and change management, and then we'll look at quality improvement. And our goal is actually on how to have a successful infection prevention and control program. So this would kind of summarize the outline of my presentation, talk a bit on quality. We'll go back to the core components of IPC because that is really foundational for any IPC program. Then we'll look at the improvements that need to be made. How do we manage change? What is one of the easiest improvement models we can use in improving our programs, continuous quality improvement, and then a few steps on how to ensure that we have successful IPC programs and we are able to sustain them. So going back to a summary of the main goal of IPC, we really do IPC so that we can eliminate, minimize, or prevent the risk of acquiring infection during the provision of healthcare services. And IPC deals with preventing avoidable infections during the provision of healthcare. So our practices, our programs are all to prevent avoidable infections while we provide healthcare. So with that at the back of our minds, we want to look at what we refer to as quality in healthcare. We can summarize quality as being doing the right thing the first time, in the right way, and at the right time. So we want to do the right thing the first time for every patient, and we want to do it in the right way at every time. The Institute of Medicine defines quality as the extent to which our health services increase the likelihood of desired health outcomes. And we do this using evidence-based methods. So if we're looking at quality in IPC, we're looking at how our IPC practices increase our desired outcome. And our desired outcome is the prevention of avoidable infections. Effective IPC is a key determinant of the quality of health service delivery, which we do so that we can achieve what we call people-centered and integrated universal health coverage. The truth is we cannot talk about universal health coverage without IPC because it is crucial to achieving that. And when we talk about health system strengthening, IPC is also an important aspect. So we aim to minimize risks to patients, to healthcare workers. And in minimizing risk, it also includes the control of AMR, the control of healthcare-associated infections, and also outbreaks of highly transmissible diseases. COVID has actually shown the world the role of IPC. At every time we've had outbreaks, actually, I think Ebola is another disease which really shows the world the importance of IPC. And in minimizing these risks, we use guidelines that are related to the core components of the IPC programs. Using this, it helps us to develop and implement effective technical and behavior modifying interventions. I was looking at the introductions of many people on this meeting. I noticed there were mathematicians, there were journalists, there are IPC professionals. And so I'm going to assume that we are not all IPC professionals. And so there'll be some reference back to the core components, the basics, and we build up from there. So looking at IPC improvement and change, because when you're talking about improvement, there'll always be changes. You cannot have improvement without a change from the usual. When you have a change from the usual, it should be towards improvement. So there is the concept of quality improvement, and this is really the healthcare system where we talk about combined and unceasing efforts of everyone. So for IPC programs to improve, it includes the efforts of everybody. So we have the healthcare professionals, we have the patients, the families, the researchers, the planners, the educators. So everyone coming together to make the changes that will lead to better patient outcomes, better system performance, and better professional development. Alethea just talked about the various players in their country in improving the IPC program, especially with the advent of COVID. So it's important that we change an internal culture, and this is one of the key and fundamental steps for any efforts in improvement when we're looking at patient safety, when we're looking at quality. So why are we asking for change? Because talking about IPC programs, implementing them, setting them up is really asking for change in the way in which we've done things, in the way in which we've practiced healthcare delivery. And even if you have an existing program, it's natural for any program to experience change over time because that's a sign of growth. If you've been practicing if you're practicing IPC now the way you've practiced it in 5 years, the way you practiced it 5 years ago, I think I would like to tell you that you need to have some change because that is a sign of growth. So when you're looking at change, there are a number of things you look at, and this applies to any program, but I'm focusing it more on IPC. You need to look at the leadership, the personnel that form the leadership of that program. You need to review your mission and your expectations. So you have an IPC program. What is the mission of your program? What are the expectations from that program? What are the resources available to you in that program? What are the changes environmentally or societally? Your society could be your hospital society. What are those things that need to change? And then what are significant events that could also lead to a change? Just like I mentioned, COVID has led, it's a significant event in the world, that has pushed IPC to the limelight. And the aim of quality improvement in IPC programs is really to ensure that at the end of all the changes we make, at the end of all the interventions we put in place, we are able to provide a safe and effective, a patient-centered, a timely and efficient and equitable care. Our patient is at the focus of anything we're doing in any of our programs. So coming back to the core components of the IPC program, this is a summary of the WHO core components of the IPC program, and it's built on what we could call 8 cores. So we have the program itself, the IPC program, but the IPC program is anchored on evidence-based guidelines. It needs to have an education and training component. There needs to be surveillance for healthcare-associated infections. And then we're utilizing multimodal and multidisciplinary strategies. So you're not basing the program just based on one strategy. There's the aspect of monitoring, audit, and feedback, because that's what leads to improvements. There's the aspect of considering the workload, the staffing, the bed occupancy rates within the healthcare facilities. And then the structural issues, the built environment, the materials and equipment available for IPC, especially at the facility level. So implementing these core components is not always easy. And for people who have tried it or who are working in it, I'm sure they can attest to that it's not always easy. It takes some time. Apart from that, it's important that approaches are monitored, and whatever we do has to be patient-centered and integrated with our clinical procedures. Particularly for us on the African continent, there is need to be innovative. There are so many innovations we will need to develop at our local levels and adapting it to local conditions. A lot of that has begun to come up, but we are still going to need a lot more. And this needs to be tailored to specific cultures and resistance level. And we need to do it using our multimodal and multidisciplinary strategies. Just a reminder, and also for people who are not aware, when we talk about multimodal strategies, there's a WHO multimodal improvement strategy, which I'm sure you can check online. But generally, it summarizes it in what we can call 5 steps. So it talks about you're building it, you're looking what needs to change in the system, and then you're teaching it. So we want to make a change. So there's the training and education part of it. And then as you're building and teaching, you want to check it. So that has to do with monitoring and feedback. And then as you check it and you find out that it's having the effect you want, then you want to sell it to others. So you are putting reminders in the workplace, telling people about it, reminding them, you're communicating it, and then you want to leave it. So that's the sustainable part of it. You want to ensure that it becomes a culture change within your system. But also, as we talk about change and as we talk about quality improvement, we also need to realize that no matter what you're doing, no matter what it is you're changing, there are usually reasons why some people dislike the idea of change. There are multiple reasons. Some may not like what's happening. Some may not like the way it's being done. Perhaps they have other ideas on how it should be done. And some may not like the fact that they are not the ones doing it. So they're wondering why you are the IPC champion. And then some are afraid of the outcome. And then there are just some people who don't see why anything should change. They like it as it was in the beginning, so it is now, and so it should continue to be. And we need to have this at the back of our minds, especially when we move into the IPC world and we want to implement changes that you can meet with and you will meet with some resistance to change. But be that as it may, how do you overcome resistance to change? There are different things you can do. One is listening to people's fear and concerns. One is ensuring that you are able to provide clarity and certainty. You should be able to demonstrate what's in it and what it involves for every person and for the whole team. Then, more importantly, if you're able to make people part of the story, you'll find out that that is one of the greatest way of overcoming resistance to change. And sometimes, especially, I know that after people have had, some very good IPC trainings, people are rearing to go, which is good. But sometimes you need to slow down and just make some gradual increments so that as this become more visible, then you get more people supporting you in the process. So if you want to look at a need for improvement, where do you start from? Especially for people who are probably new on the IPC field and are starting a program, but really do not know how to proceed. Identify what are the areas for change and define them. Set out your aims. So what do you want to change? Like I said, have gradual increments. So you want to change 1 and 2 as a start. And then once you've been able to achieve numbers 1 and 2, you can move to 3 and 4. Then establish measures. This means that, okay, I want to change this. How would I measure to know that a change has been made? And how do I measure that progress is being made? And then you test the changes. So if we are doing it this way and we want to begin to do it this other way, how do we test that this has made an improvement? And then you begin to implement those changes. So we also need to realize that whether we are working in a facility or we are working maybe in a national or provincial or state program, we work within a system or we work within systems. And so our local community is our microsystem. And in any system, you've got leadership, you've got staff. For IPC, our focus is the patients. And then you have the performance. And these are things that need to be monitored and evaluated and measured from time to time. So when we're talking about leadership, in any system, you're going to need strong leadership. So if you're an IPC focal person, then you are a leader. And you need to get a team that will help you to have strong leadership. Critical to leadership is a great organizational support, and you need to focus on your staff. You focus on the professionals. You also look at those who are non-professionals. Then it's important that your staff are educated and trained, and you recognize the interdependence of the care team. Then with the leadership and the staff, you need to look at your performance. Your performance should be result focused and also should be process improvement focused. So for your performance, you're looking at results, you're looking at the improvement of your processes, and also patient. It should be patient-centered focus. In other areas, you look at community and market focus. And for us in Africa, this is where innovation and local adaptation comes in place, because sometimes we do not have the perfect situations. But within our community and within our market forces, how do we deal with that? And in the IT world, information and IT orientation is also a great consideration. Then in our microsystem, we also need to assess our improvement. So we look at we call them the 5 Ps for improvement assessment. So what is your purpose? What is the purpose of your IPC program? What is your aim? What is your mission? Remembering that the patients are our reason for doing our work. Also considering the people, the staff who take care of the patients. Beyond the staff, you look at the relatives and others. And then you look at the processes. What are the interrelated processes that make up our microsystem? So you have the IPC committee. Some other people have the AMR committee or therapeutics committee. Other people have the patient safety committee. So these are all interrelated processes that make up the microsystems. And then you look at the patterns, the way we work, the way we measure what we do, and the measurements, data, instruments, and all. So in defining changes for IPC programs, we need to define the changes we wish to see and plan for how to go about making those changes. So this cycle just describes what we call the change management process. So the first thing is, what is it that you want to change? And we call that the request for change. The second is, this change, what impact would it have on our healthcare delivery at the end of the day? If it is, there are small changes that could have huge impacts, and those are the type that need to be approved. But sometimes they are very large changes that at the end of the day, they just have a small impact on the whole delivery. Sometimes they might need to be denied. And so for the ones that have been approved, the next step will be implementing the change. And for any change that is implemented, it's important that it is reviewed and it is reported. So for the improvement process, we look at the project phase, that's defining what you want to do. The diagnostic phase is also like what I called the impact analysis. And then now actually doing the intervention. And for the intervention phase, we have what we call the PDSA cycle. So P stands for planning a change, D stands for doing it in a small test, S stands for studying its effects, and if it's effective, then A means you act on the results, you implement it on a wider and on a larger scale, and then you check the overall impact, and then most importantly, you want to sustain improvements. So many times in our programs, we put in an intervention, but we also need to plan for sustainability. So for a basic improvement model, like I said, is the PDSA. That's the plan, do, study, and act. But in the planning, you first of all ask your question, what are we trying to accomplish? And then how will we know if the change is improvement? And that is where your do, act, and study come in place. And if it results in an improvement, then how do we upscale to make sure that we have a larger improvement? If it doesn't result in an improvement, then what other changes can we make that will result in an improvement? So this summarizes the PDSA cycle. You plan, what do you want to change? What do you want to test? You do, you carry out the plan. S, you study. In other words, summarizes what lessons you have learned from what you planned and what you did. And A is acting, determining what changes to be made or to continue with. And it's a continuous cycle, so you keep doing PDSA over and over again. And this brings us to the concept of what we call continuous quality improvement. Remembering that problems are in the process and not in the people, and that processes tend to have unintended variations, which could lead to unwanted variation in outcomes. So the PDSA is a continuous thing, and then continual improvement is what we want to see in our IPC programs. So in the PDSA, we have the intervention phase where we identify appropriate interventions. We first of all identify what the problems are, and then the next is identifying the appropriate interventions, implementing the changes identified, and that undertakes one or more PDSA cycles, and it keeps going on. One of the things I think we forget to do, and which would also help our programs, is not just implementing the changes, but measuring the effect or the impact of those changes and interventions. Then apart from measuring, recording the results, revising the interventions, and monitoring the impact. I'll use a small example here. Assuming you want to improve hand hygiene within your health facility, and you've decided to put in some interventions, it's important you measure the effect of those interventions, and not just measuring. Whatever you measure needs to be recorded, because it serves as something you compare future interventions with, or the progress of your program as you move ahead. And then you revise the interventions, you monitor the impact, and then you plan again. So that is using the PDSA cycle as it needs to be done. Then at the end of the day, to sustain the improvements, there are a few things we need to do. So you've put in some interventions, you've developed a process. It's important you standardize the systems and the process. And this is done by documentation of a number of things. It could be the policies, the procedures, the protocols, and the guidelines that support that process or system you've put in place. The next will be the measurement and review of your practice to ensure that that change you implemented has become the standard within your facility or organization. And then that change you implemented, you need to train and educate all staff so that everybody complies with the new standard. And that's the way by which you can sustain improvements in your IPC program. So in summary, I'll end with these 5 steps for a successful IPC program. I think in a way it's a summary of the entire presentation, and it's a summary that is included in the WHO core components of the IPC program. So step one is preparing for the action. So what are those changes you need to make? What are the things that you need to be in place? What are the resources, human and financial? What are the infrastructures? What are the planning and coordination of activities and the identification of roles and responsibilities? Then step two is making your baseline assessment, or an assessment at the point you reach to make that change, because that helps you to be able to measure your progress and also to measure the effect of the change and the overall impact. So you want to conduct an exploratory baseline assessment of the current situation, identifying the existing strengths and weaknesses. If it's a program, you can use the WHO IPC core components, the IPC assessment framework, or you can even just do a little tool like the hand hygiene self-assessment framework. Then step three is developing and executing your action plan. That is the P of your PDSA cycle. And then you plan, you act, you study. And then step four will be assessing your impact. That's the study part. So you conduct a follow-up assessment. And then step five is the A part. You're acting out based on the effectiveness and your assessment. So you sustain the program over the long term. And this is an important step in the cycle of improvement. So you want to develop ongoing sustainable action plans and review the schedule to support the long-term impact and benefits of the IPC program. So thank you, and over.
Thank you so much, Professor Olanyenka, for that comprehensive presentation on leadership, management, and quality improvement for successful and sustainable infection prevention and control program. Thank you so much. And at this juncture, I would like to thank all our presenters for today, Dr. Patrick Kabwe from ACDC, Ms. Alethea Mashamba, Professor Debola Olanyenka. I would like to thank you all for your very informative presentations, which I'm sure our participants will also agree to. And then at this juncture as well, I would like to hand over to Dr. Yewande from ACDC to handle the Q&A session. Thank you.
Fantastic. Thank you so much, Non. And thank you once again to all of the presenters for today. On my panel today, I'm pleased to announce that we have experts from ICANN, from WHO Afro, WHO EMRO. We have also from Africa CDC. So on that note, we would start our questions and answer. Please keep your questions coming and put them in the Q&A chat. We have a few questions for you, Mashamba. There's a particular question on focused on Zimbabwe, and it's on how is Zimbabwe including client management, skill building, or customer management in IPC? Because client engagement is critical for the success of IPC interventions. So I think that question is on how you engage customers or clients, as they may be referred to in various settings. Over to you.
Thank you, Dr. Wande. Remember when I said we established various pillars, there's a pillar that deals with communication. In addition to that, every hospital has a public relations officer, and their role is to ensure engagement of the public, in addition to the IEC materials that we have translated into all the local languages. So that is our attempt to engage clients. Over and above that, there is also a media strategy that the Ministry of Information flights on national TV and on radio. So it's a collective engagement of clients, but both at community level and at hospital level. Over.
Thank you very much for that. So I think Prof. Olayinka, there's a concern from one of the participants that should we really be focused on only saying patient-centered, because ideally beyond patient safety, I think what the person is trying to say is there should definitely be considerations for a very holistic package. There should be considerations for healthcare worker safety. So I don't know if you'd like to talk a bit about that, about just why we keep saying that, why we say patient safety, why we use that term when we're talking about IPC. Over to you, Prof. Olayinka.
Okay, thank you for that. So IPC is not just for the patient, because when I started my presentation, I talked about the protection of the patient, the healthcare worker, and by extension, the community. But many times we look at it as patient-centered, because if you're looking at a healthcare facility IPC program, the patient is actually the focus of the healthcare facility. And in protecting the patient, you actually end up protecting yourself. So we may use the word patient-centered, but it extends to everybody. If you're able to protect the patient, you protect the healthcare worker, you protect other visitors within the environment, and by extension, that gets to the community. Over.
Thanks very much for that. This question is not, I think this person is just curious about case management, and I see that it's popping up a bit. And I know that my colleague Patrick and the team at Africa CDC have similar webinars that focus on solely on case management, and they're sort of available documents or modules or that people can access. So Patrick, if you'd like to share about sort of the curriculum or where they can log in to get more details around case management, because I'm seeing that question pop up a bit.
Thank you, Dr. Wande. We have a number of guidelines actually on case management that we have done as Africa CDC. So those are actually available on our website. So just access our website and we'll be able to see most of the case management guidance documents. Then in terms of the case management webinars, so those are actually held every Thursday, but for now they are on hold. So we are trying to change the style in which actually we're doing those webinars. So once they are restarted, I think I should be able to share all the details so that those that will be interested can be able to participate in those trainings. Over, Wande.
Thanks very much. I think I've seen a few questions around IPC diplomas. I believe that it must have been mentioned a bit, and I'm quite aware that ICANN does have certain diploma courses available online. So Prof. Shade, if you'd like to speak to it, I'm seeing quite a few questions around IPC diplomas and how to get around it.
Thank you very much. I actually did say, but I think they were asking about the Zimbabwean diploma, but there are quite a number of free training for online courses, especially from the WHO, etc. Most of the ones from ICANN, because we would like to take you through IPC. Because of the dearth of, the lack of really trained manpower in IPC in the broad sense of the word, we believe that it's, apart from those courses that you take, just to sort of protect yourself. For you to be a practitioner, you need to be properly trained in how to actually drive the process of IPC in your facility. So most of the courses for IPC in ICANN, they're taught courses. You need to come in and get your certificates. And I think that's the same thing for the ICAS, in Zimbabwe. Thank you.
Thank you so much, Prof. Shade. Zaid from WHO Emerald, if you're on the call. I think a lot of people are, I'm wondering why there's a lot of concern around case management and differentiating IPC pillars. But I mean, from the WHO Emerald experience, it'll be good for you to share your perspective on how to undo and avoid duplication with case management and IPC pillars, at least in the context of COVID-19. Over to you, Basim.
Thanks, Yuanda. Do you hear me?
Yes, I can.
Yeah, thank you very much. I think they are. I totally agree that they are somehow correlated, and sometimes people switch between the two concepts. But case management refers always to how we manage the patients, what sort of treatments or supportive therapy or other modalities to manage the symptoms and signs of the patient. And here I'm talking specifically about COVID-19, and I think it applies also to managing other diseases or other infectious diseases as well. While infection prevention and control is how we provide all of this in a safe way that doesn't result in a transmission of any infection, whether we're talking about COVID-19 or others, to patients or to healthcare workers or to any other people around in the area where the health services are provided. So this is simply what would be the difference between the two pillars, but I totally agree that they are very, very correlated. Over.
Thanks so much for that intervention. So I move back to you. Dr. Mashamba. There are a few questions around Zimbabwe's experience. So this is this concern or this question is, why update only nursing tutors for training their students and not other institutions such as the medical schools or the pharmacy schools, health assistants and other health professional trainings? I think you must have mentioned something around nursing, and this participant is curious to know why the trainings are not expanded beyond just the nursing trainings, but to be expanded to medical schools, pharmaceutical schools, and health assistants. Over to you.
Thank you, Dr. Wande. I will respond and also ask Prof. Robertson to come in. When we initially started the medical school, the case management was leading the training of the doctors in terms of COVID response. Then we realized that in the training of the doctors and the nurses who manage patients, there would be duplication of the cases. That is why we ended up developing 8 modules that include case management and IPC. But the medical schools themselves have been training separately in terms of COVID responses, but using the same standardized modules. I'll ask Prof. Robertson to come in because she recently retired from the medical school at the UZ to share how they were training in terms of COVID response. Over.
Okay, hello. Can you hear me? Hello?
Yes, we can hear you.
Yes.
Okay, just to add on to what Aletta has just said, in the medical schools, we had already begun to strengthen the IPC component of their training in both their 3rd year when they start their clinical ward rounds. We introduced IPC training there, and then also in their final year. We also had a training module for physio and occupational therapists, and training of our MPH students as well. So although we had not got round to training every single student professional, we had begun to make inroads into some of the curricula. So when COVID-19 came along, we were asked by our College of Health Sciences to train trainers within the college, and that we did. They came from different departments, the teaching laboratory, the preclinical programs, to look at different aspects of infection prevention and control. So that's how we involved other colleagues, and we brought them on board. And the program was led by a group. I had just retired, but the program was led by a group of lecturers within the College of Health Sciences who moved this forward, and we worked with them. Thank you.
Thank you so much, Prof. Valerie, for the intervention. So I'm just, maybe colleagues on the call need more details, and this is coming back to you, Dr. Mashamba, to talk a bit about what the curriculum of your IPC diploma looks like. I see quite a number of questions on that, so it will be helpful for you to just talk us through what the sort of the curriculum of the IPC diploma looks like. And yes, and what are the challenges for implementing or rolling out this diploma level trainings?
Thank you very much. We are working with the University of Bindura. As ICANN, we assisted in setting up the diploma and working out on the module. This is a part-time modular course made up of 6 modules. I hadn't prepared for this, but I will outline some of the modules that are covered. The first one is basically on basic microbiology, and the students are multidisciplinary, and it's part-time, 2 weeks in when they have lectures, and they go back to their stations to apply what they will have learned in that particular module. Then the second module is on a leadership and a training. So the third one is on, then they also go back to their stations to establish a program. That's basically the basic IPC training. Then there's the third module, I think it's on surveillance and monitoring and evaluation. Prof. Robertson can come in here because I had not prepared to outline the diploma course. And then the other module I know is on research and development. I forget the fourth one. Prof, you can come in, but the important bit is every module has a teaching session and a practical applied session where they go back to their stations to apply and investigate how to improve IPC practice at their stations. And then they also write exams at the end of each module, and they do the coursework, and both the exam and the coursework contribute to the diploma. I know I've missed one of the modules. Prof. Robertson can come in there. Thank you. Over.
So I think the only 2 that were missed were decontamination and hospital design. And I'd like to stress, because if you want to see the curriculum, you'd have to communicate with the University of Bindura in Zimbabwe, because they have ownership of that curriculum. And we received support because in some areas we don't have the expertise needed, hospital infrastructure. We have some skills, but not perhaps enough at diploma level, the same with decontamination. So the Infection Control Africa Network provided expert advice and brought on board for us specialists in those areas. So we were able to run the program. We ran it, the first group of students from 2018 to 2020. And now we've just started another, it's a 2 years, a letter said, a two-year part-time course. Thank you.
Thank you very much. And Prof. Alainka, this question would go to you. The question is just pretty simple. It's what key aspects should we consider when setting up an IPC National Action Plan? So if you're happy to take that, I'm guessing the person is wondering about IPC national strategies. What should be considered? Over to you.
Okay, thank you. I think one of the first things that will need to be considered is that every country ideally should have an IPC policy, and that's really where it starts from. Then apart from having the IPC policy, it's important that there needs to be like a national structure for IPC. You'll find out that sometimes you just have different facilities running programs, which may be good, but that way it doesn't go across the whole country. But if there's a policy and if there's either a technical working group or committee, as it is made, as it might be named, at the national level, and such a technical working group or committee needs to be multi-sectoral and multidisciplinary so that the key people can be carried along. So having the policy, having the group, and then a structure from the national level right down to the community level is important. Then that committee can sit together, do a situation analysis of IPC in the country. And based on the reports of that, then a national IPC plan can be developed from that. So there is no pre-made plan, so to say. The plan will speak to the situation in that country. I hope that has been helpful.
Thanks very much for that. Basim, this question is to you. How do we establish the quality improvement teams in IPC? If you'd like to take on that question, and then we move to the next batch of questions. Over to you, Basim.
Thanks. Could you please repeat? I couldn't hear well.
It's on establishing quality improvement teams for the IPC committees.
Okay, if I understand the question correctly, I think IPC and quality are very much related. And IPC is a key element of quality improvement in healthcare settings and should be one of the major process and also outcome indicator for improvement on quality. On the other hand, also IPC cannot achieve its goals without quality improvement. Let's put it this way: without quality improvement direction and without addressing the issues and the challenges of infection prevention control from the quality point of view. So the two disciplines are very much related, and it's very important for the IPC teams to be educated and trained in quality improvement and the quality cycles, and also the quality measures, processes, analyses, and the quality program in general. And from the other side, also the quality improvement teams, and this is very much important. One of the IPC core components is the linkage between IPC teams, committees, and the quality teams or patient safety teams within the healthcare setting. They should work in hand. They should collaborate. They should jointly work together to improve both infection prevention control and quality aspects. I hope this answer the question. Over.
Thanks very much. So there's a question around the epidemiological situation, particularly from East Africa. So Patrick, if you are still with us, if you'd like to just, it looks like, yeah, definitely there's a very sharp increase in the cases that we are seeing in the eastern part of Africa. So the question is just, are there particular reasons compared to what we are seeing in other parts of the continent? So over to you, Patrick.
Right, thank you, Wendy. Yeah, indeed, actually, there's actually a worrisome increase in number of cases in the eastern region, shown from the AP updates. And there could, of course, be various reasons to why this is happening. And I think one of the about 17 countries that have recorded the B1351 variant, you know, and this variant actually seen in South Africa, it was actually quite transmissible. So this is also actually circulating, especially in Kenya, where they've actually confirmed the third wave of the COVID-19 outbreak there. So that would actually probably explain why the numbers actually increasing in that region. And of course, we have issues to do with probably a lax in terms of the adherence to the public health and social measures. So those could actually explain what's happening. But I think the worrisome aspect of it is actually the circulating more transmissible COVID-19 variant, that is the B1351, that's circulating in parts of that region. Over.
Thanks very much. So there's a question that I think that I'm going to really allow all of the panelists to speak a bit about, then try to wrap it up from the Africa CDC sort of perspective. The question is, Prof. Adebola must have mentioned something around changes and the fact that they're not easy. So this is, governments in Africa are behind investing in healthcare. How do we achieve such efficient and equitable care, and any care at all, and IPC measures in various circumstances that exist for each country? So ideally, I think I would, because this is something all of my panelists are really passionate about, I'll let Prof. Adebola start, then I'll move to Dr. Mashamba, then we go to the other panelists to give us their thoughts around this.
Yeah, usually when you are going to make a change, somebody must be willing to be the person to build the cart. Governments many times are usually more focused on what brings funding into the economy and so on and so forth. And I think this is one of the reasons when AMR, what has actually pushed AMR in being a topical issue and in which countries have signed up to develop action plans and implement against AMR is because an economic case was made for it. So I think with regards to IPC, we probably need to start looking at how to make an economic case for IPC. And what I mean by this is showing that the cost of prevention is much less than the cost of treatment when IPC fails. You'll find out that because of the economic impact of COVID, for example, governments all across the world have risen up to respond aggressively to COVID because it's had an economic impact. So from my perspective, one way I think we can get government buy-in into IPC is making an economic case for the benefits of IPC within our healthcare facilities.
Thanks for that. Dr. Mashamba?
Hello. I would like to add that as you observed at the onset of COVID-19, over the years, there'd been poor investment in public health. We were surprised to realize that most health institutions didn't have a budget for IPC. IPC would be under surgical sundries or any other supplies. So in a way, like I said, the onset of COVID was a blessing in disguise. That's where governments or ministries of health realized that they didn't have running water, they didn't have working toilets, they didn't have all the key issues that should have been in place anyway before COVID-19. So in a way, for sustainability, we know that most governments have improved in terms of their water and sanitation supplies, in terms of having budgets for IPC. So like Prof said earlier, making an economic case to invest more in health, public health development will definitely assist in preventing future outbreaks, because all those things will be in place and hopefully they will be maintained and we won't be caught unawares like we were done by COVID-19. Thank you. Over.
Thanks very much. I'm Niniola Williams from DRASA, if you'd like to touch a bit on that.
Yeah, thank you, Wande. So I think it's interesting that, you know, the comment was made about African countries. I think IPC and budgetary allocations is a challenge across the world. Of course, it's worse in resource-limited settings like ours. However, I don't think that means that we should give up or that we should wait until we see the necessary levels of investment and funding that we require. I think it's very important that while we advocate for changes at the national level, we can start small. And that's something that I took away from Prof. Olainka's presentation, that it doesn't mean we have to take on everything at once, but we can start small and be creative in how we achieve what we need to get these IPC interventions done at the facility level, while of course still advocating for the budgetary changes to be made. Okay.
Fantastic, thanks. Prof. Shadid, if you would like to add on to that.
Thank you very much. Yes, I will. It is true that we do need a budget for IPC. However, as Nini said, a lot of the things we need to do are not very expensive. And they're things that with some creativity, we can get around to do. I think a lot needs, what you really need at the beginning, because as Professor Olainka said, if there's no economic case for it, the management and governments, and I will say the leadership, even at the hospital level, at state levels or provincial level, they're looking at other things that one have immediate consequences. The problems with IPC is that the consequences are not always immediate, or even if they are, they're not easily linked to the absence of not doing something that you should have done. So they usually are not the focus, but you start small. You identify something that would have a lot of impact and would matter. And I think this is where our need for real advocacy comes in. We need to understand what makes people tick. A professor of mine who is an anthropologist, a sociologist, told me, he said, people don't do things from altruism. They do it because there's something in it for them. So if we're going to start a program of IPC in our facility, it's great to know what makes your management tick. What is your area? What is the area that the CMD or the medical director, what makes him tick? So if he's a surgeon, maybe one of the things you should first address is show him the difference IPC makes in surgery so that you get him on board. If he's a pediatrician, or even if he's not, somewhere that's something that, speaks to him or her, then you get their attention and then they see the value of it. Many times people don't see the value of it. And unfortunately in Africa, because of all our epidemics, somehow IPC has been confused with an epidemic response. They don't see it as something that you do every day in the hospital, in the healthcare facility to reduce infection. So to them, it's always about, there's no epidemic. So what's this business about IPC? You just need to wash your hands and wear PPE. So I think, as Nini said, you start small, you choose your battles. You must always at the beginning focus on, how do I get people interested? What would catch their fancy or catch their attention that would help them to support me? And then you look for people like you so that you continuously are talking to each other, helping each other, coming up with new ideas, repurposing things that exist in the hospital, changing things around. Things like changing the workflow don't cost money. They just mean you need to understand IPC. Talking to people to say, when you want to insert that cannula, clean properly, you can't drop it there. Those don't cost money. So a lot of things in IPC. In fact, I remember when I was starting, they said to achieve 95% of the things you do in IPC, you don't really need money. It's when you want to go for the real, almost like zero infections, that then you start spending a lot of money. For many of us, the things we need to do: get the environment clean, teach them how to clean properly. They're already cleaning, the resources are there, so use them better. So for a lot of things we need to do, it's about optimizing what already exists without actually changing a lot of the budget. And that's another thing you can talk to management about. You don't have to change anything, just let us do it right. And I think if we're thinking like that, we start with those before we move on to things like, we need money for this. Thank you.
Thank you very much. We're slowly getting to the end of this, but I think it's important that for us at the Africa Union, all of the points around sustainability, funding, letting government understand, making an economic case, things that we have considered. But most importantly, one of the things that we are really keen about is to get that government back in, because even if we make economic cases, if the government do not prioritize it, if they don't see it as a sort of right for healthcare workers and for patients, we would not be able to move this forward. So one of the things that we are also doing is having legal backing. So very soon we will be putting out our legal framework, which really undermines everything that all of my panelists have highlighted as sort of the way forward for the continent. This is a continental framework. So ideally, government will be bound to at least have minimum standards at various healthcare facility levels, and have at least a functioning IPC program or policy to guide things that are being done across various cadres of the healthcare facility level. So that is what we are doing at Africa CDC, and we are doing this very much in collaboration with WHO, ICANN, and several of my colleagues who are also on this call. So I think we are 2 minutes way past our time. I'll hand over to Noel to wrap us up. But thank you very much to the panelists and to the speakers for today. I think we've had a very, very interesting session. Please join our Telegram group. We will be able to provide some additional answers in case we didn't answer all of your questions today. Over to you, Noel.
Thank you so much, Dr. Yawande, for that very informative Q&A session. Just to round up, thank you to all the panelists, thank you to all the presenters, thank you to you as well, participants, for taking time out to attend our session. Just to remind you as well that we've got a French session that comes on every Friday, but then it comes 1 week. It's delayed by 1 week to the English session because of the recent holidays that we had over this last weekend. Just also to remind you that the lectures are also available on the ICANN and ACDC websites, and all sessions are recorded, as I mentioned earlier, and will be made available to all of you that have registered. Also, I'd like to thank all those behind the scenes for also making this possible. And if you've got any questions that are still burning, all our participants, please send them to Susan Cassie. Cassie is KESSY at Africa-union.org, or send them to ICANN. You send them to Anna at icannetwork.co.za. .za. And with that being said, thank you so much for a fruitful day and hope to see you next week. Bye.
Thanks, bye.